I will hand the reins over to Ananya and yeah, take it away, Nuns.
Okay. Hey guys. So like I said, my name is Ananya. I recently graduated from UMHS. So I'm just going to introduce the doctor first and then hopefully she shows up. So Dr. Ware is going to be our attending physician today. So Dr. Ware received her BSN from the University of Illinois, and she worked in Chicago as a labor and delivery nurse for 10 years before she decided to go to med school, and she actually went to AUC. And then she went to the University of Wisconsin, where she did her obstetrics and gynecology residency and internship. And then she attended the Medical College of Georgia for her fellowship in maternal fetal medicine. She stayed on as faculty and is still an associate professor there. And she now also owns her own private practice that specializes in maternal fetal medicine, consultation, and prenatal diagnosis. So she's an expert in prenatal diagnosis and fetal management. She has expertise, and I say this very highly, expertise in targeted and genetic ultrasound and cervical and abdominal cerclage. So you can go to the next slide, Sam. Okay, so today we're going to be talking about the uses of intrapartum magnesium sulfate before preterm birth and the implications of the 2023 Magenta trial. So first we'll talk about why we use intrapartum magnesium sulfate. So currently, the in utero exposure to magnesium sulfate before early preterm birth appears to decrease the incidence and severity of cerebral palsy. So as of right now, we are typically administering impending preterm births less than 32 weeks gestation for neuroprotection. Now, you'll also see, and some of you probably already know this if you're in your clinicals, magnesium sulfate is also used for tocolysis and for seizure prevention in preeclampsia and eclampsia, but that's a separate matter. Today's topic will only be talking about the uses of magnesium sulfate for neuroprotection in the fetus. So like I said, we're going to be talking about its implications on the effects of a fetus or a child developing cerebral palsy. Cerebral palsy is the leading cause of neurological impairment in young children, and preterm birth and low birth weight are some of the most important risk factors for that. The mechanism for the neuroprotective effects of magnesium sulfate is not well understood, but there's a couple of mechanisms by which it's thought to occur. So I listed some of them. One of them is thought to be the stabilization of cerebral circulation by stabilizing the blood pressure and normalizing cerebral blood flow. Also, protection against oxidative injury via the antioxidant effect, prevention of excitatory injury by stabilizing the neuronal membranes and blockade of excitatory neurotransmitters like glutamate, and protection against inflammatory injury via the anti-inflammatory effects. Also, I wanted to mention that although maternal administration of magnesium sulfate has not been associated with a decreased risk of fetal brain injuries that can also be a cause of cerebral palsy, such as severe intraventricular hemorrhage or cystic white matter damage, it is associated with the reduction in cerebellar hemorrhage in preterm infants. So we can go to the next slide. So prior to this 2023 Magenta trial, there have been plenty of randomized trials and meta-analysis that have supported the use of intrapartum magnesium sulfate, and I've listed a couple of the big ones. So the Australasian Collaborative Trial of magnesium sulfate, the BEAM trial, the PREMAG trial, and then the Magenta trial as well. In 2009, there was something called the Cochrane meta-analysis of magnesium sulfate for neuroprotection of the fetus in pregnancy at risk of preterm birth. And they took all of these studies and created a meta-analysis, which basically supported the use of magnesium sulfate. And you'll see on the right-hand side, there's a graph that kind of compares the different trials, the subjects that were used, how they tested, and then the outcomes, the primary and secondary outcomes they were looking at. And you'll see that most of them will show that there was a decreased risk of children developing cerebral palsy with the use of magnesium sulfate. So we'll go to the next slide. Okay, so these are kind of like the summary of the major findings. So when they were looking at the primary outcome of cerebral palsy, any cerebral palsy was significantly reduced in the overall population. There's a 3.4% versus a 5% reduction in risk. And then you'll see the confidence interval, which I highlighted, also shows that this was significant. And that second part where it says the neuroprotection trial subgroup, some of these trials, they actually looked at all of the uses of magnesium sulfate. So the neuroprotection that we're talking about today, as well as the uses for tocolysis and for seizure prophylaxis. So they had different trial subgroups depending on which of those features they were focusing on. So for the purposes of this talk, we're only going to look at the trial subgroups that were dealing with the neuroprotective effects. So in those trial subgroups, they also showed a significance in reduction of cerebral palsy in the groups that were treated with magnesium sulfate versus the placebo. So for gross motor dysfunction findings, there is also a significant reduction in the magnesium sulfate group versus the placebo group. So, and this will be an important point to keep in mind when we talk about the Magenta trial. But when they did the combination of death or cerebral palsy, there was no significant reduction in the overall exposed population. But it was reduced in the neuroprotection trial subgroup. And then in the stillbirth or pediatric death, there was also no significant reduction in the group exposed to magnesium sulfate versus the groups that were exposed to the placebo. So basically the importance of this slide is that there's concern because of these competing outcomes with this finding that, oh, magnesium sulfate has no significant effect on the combined outcome of death or cerebral palsy. But it is possible that the non-significant difference in the combined outcome is due to an increased risk of fetal death or infant death in a subgroup of magnesium exposed fetuses. And that was suggested by 2 of the trials. So for this reason, you'll maybe see some clinicians who don't want to administer magnesium sulfate, even though there were protective effects against cerebral palsy. But on the other hand, the combined outcome of death or cerebral palsy that was reduced significantly when only the trials designed specifically to assess the neuroprotective effects that were analyzed. So you'll still see a majority of physicians who are going to give their patients magnesium sulfate, even though some of the data says that it wasn't significantly reduced. And by the way, guys, like Sam said earlier, if you guys are getting confused by any of this, if you have questions, please feel free to ask away. Okay, so the clinical use. So the precise dose, duration, and timing of administration of magnesium sulfate has not been fully established. So different attendings or different doctors are going to give their dosages slightly. So you can see physicians giving a dose as early as 23 weeks gestation, and they can give it as a 6-gram loading dose with a 2-gram per hour maintenance dose. That's a little bit on the higher side. So like most people and like up to date is going to recommend a lower starting dose. So they'll recommend a 4-gram loading dose over 20 minutes with a 1-gram per hour maintenance dose. And treatment stops after 12 hours. You can retreat a patient if they're continuing to have symptoms, but I believe you have to wait at least 6 hours between their first dose and then when you're going to give them a second dose. So who do we give this to? We give this to any pregnancies that are at risk of preterm birth within 24 hours if they are appropriate candidates for magnesium sulfate neuroprotection. So this includes pregnancies that are at risk or have preterm pre-labor rupture of membranes, preterm labor with intact membranes, or planned medically or obstetrically indicated preterm delivery. Some other things to keep in mind is there are contraindications to magnesium sulfate. So it's contraindicated in patients with myasthenia gravis because it can precipitate a myasthenic crisis. And it should be used cautiously in patients with myocardial compromise or any cardiac conduction defects due to its negative or anti-inotropic effects, and also in people who have impaired renal function. So the gestational age considerations to keep in mind. So for the lower limits of the gestational age, none of the randomized trials for the magnesium sulfate included pregnancies that were less than 24 weeks. So we don't generally give it for anything less than 24 weeks. And part of that is also because of viability of pregnancy. Most pregnancies under 24 weeks are not usually viable. And then for the upper limit, this is important to note. So magnesium sulfate for neuroprotective effects is usually limited to pregnancies less than 32 weeks of gestation, because the majority of the data from randomized trials that showed efficacy were derived from pregnancies that were less than 32 weeks. And you can go to the next slide. Okay, so we're going to talk about the 2023 Magenta trial, which was just recently published. You can go to the next slide. Okay, so the purpose of the Magenta trial was to assess whether giving magnesium sulfate versus a placebo to women immediately prior to preterm birth between 30 and 34 weeks gestation reduces the risk of death or cerebral palsy in their children at 2 years corrected age. So for methods and design, this was a randomized multicenter placebo-controlled trial that took place in multiple hospitals throughout Australia and New Zealand. The inclusion criteria included women at risk of preterm birth between 30 to 34 weeks gestation, where birth was planned or definitely expected within 24 hours, with a singleton or twin pregnancy and no contraindications to magnesium sulfate use. Exclusion criteria included women who had a higher order multiple pregnancy, had received antenatal magnesium sulfate in the current pregnancy, or if magnesium sulfate therapy was considered essential for the treatment of preeclampsia. So for the treatment group, there were 2 treatment groups. The first one was women in the magnesium sulfate group that were administered 50 mL of a 100 mL infusion bag containing 4 grams of magnesium sulfate heptahydrate. And women in the placebo group were administered 50 mL of a 100 mL infusion bag containing isotonic sodium chloride solution. And both of those treatments were administered over 30 minutes. For the sample size, it was 1,433 pregnant individuals and the resultant 1,676 children. So there are multiple assessments that were taken over the span of 2 years. So the follow-up after birth until the time of primary discharge for both groups included pregnancy and labor data that was extracted, as well as postnatal and neonatal data after discharge by a masked research assistant. There was also follow-up at 6, 12, and 18 months of corrected age. And then all surviving children were formally assessed at 2 years of age by a developmental pediatrician and psychologist or another assessor that was trained to administer the Bayley scales. So the Bayley scales are used to identify children with developmental delays, and they assist in intervention, planning, and chart progressing. And they're commonly used as a research tool for children. So they assess 5 main domains. It's cognitive, language, motor, social, emotional, and adaptive. So some of the things they were assessing were gross motor function, psychological assessments, behavior, and then other general health, health resource utilization, blood pressure, body size. And another thing to note that was important is all the assessors were blinded to the treatment group assignments. So the primary study, yeah, of course.
Hi, Ananya. So you
Hi.
mentioned in your clinical use slide that a lot of times they're giving a loading dose and then an infusion over like 12 hours. But
Right.
is it in this trial, they're only giving like a pretty small loading dose and that's it?
Yes, and that will be an important point later on when we discuss the implications of this trial. So it's good that you noticed that and hold on to that. But yes, they only gave 1 dose. It was the 4-gram loading dose over the 30 minutes, and that was it. So the primary study endpoint that they were looking at was the combined incidence of death or cerebral palsy, which was defined as stillbirth, death of a live-born infant before hospital discharge, or death after hospital discharge before the 2 years corrected age, and then any cerebral palsy. Now on the right, you'll see the table that is showing you how they classified severe disability, moderate disability, mild disability, or no neurosensory disability. This is important for the secondary endpoints that they also took data points of. So on the next slide, you'll see the secondary study endpoints that they had for infant, the child, and for the mother. So for the infant, I listed some of them. There's a lot, so I'm not going to read every single one of them, but some of the big ones, they did look at health outcomes that were important for mortality and morbidity, such as, stillbirth or intraventricular hemorrhage or cystic periventricular leukomalacia, neonatal encephalopathy, ARDS, PDA that needed treatment, necrotizing enterocolitis. Those are just some of them. And then for the child at 2 years, they looked at the individual components of the primary outcome, including the severity of cerebral palsy. So the table that was on the previous slide, they classified, each of those kids into one of those categories if they had one. Any other neurosensory disability, such as blindness, deafness, or any other developmental delay. And then they also noted the general health of the child. And then for secondary endpoints, they also looked at the mother. So they looked if mom had any serious adverse cardiovascular or respiratory outcomes. So whether that was maternal death, cardiac arrest, or respiratory arrest. They also noted any side effects of the infusion. So common ones were like nausea, vomiting, flushing, dizziness, blurry vision, and then any incidents of postpartum hemorrhage. Okay, so the findings. So what did it find? Basically, the trial found that death or cerebral palsy at 2 years corrected age, which is the primary endpoint, was not significantly different between the magnesium and placebo groups. So it was 3.3% versus 2.7% respectively. And you can also see the risk difference and the 95% confidence interval. And then some other important things to note was components of the primary outcome did not differ between the groups. However, they did also see that neonates in the magnesium group were less likely to have respiratory distress syndrome versus the placebo group, and less likely to have chronic lung disease during the birth hospitalization. And then there were no adverse events for the neonates, but adverse events were more likely in pregnant individuals who received magnesium versus placebo. Okay, so what does this mean? Are we going to stop giving patients who are at risk for preterm birth magnesium sulfate because it doesn't do anything? So the short answer is no, we're still going to give patients magnesium sulfate. And part of it is when we look at the findings, kind of what Alex had brought up, there's some inconsistencies, right? So one of the big ones was if you looked at the incidence of death or cerebral palsy, it was low in both groups. So magnesium group, it was 3.2%, and in the placebo group, it was 2.7%. And what does that mean? Well, it probably means that the study was likely underpowered to find an effect. And for those of you who are, new and maybe you're still trying to figure out, like, how do we look at a study and kind of analyze it? One of the major things is power. So power of the study is the probability of detecting a true effect in the experimental study. And there are different factors that can affect the power, but two of the biggest factors that can affect it are sample size and effect size. So chances are they probably didn't study enough people to get a true sense of how magnesium sulfate affects the population. Another thing that Alex brought up was that this trial only used a single 4-gram bolus of magnesium alone, whereas many of the other large-scale trials also provided an ongoing infusion, which is what we do in practice today. So that kind of complicates the comparison between this Magenta trial and previous data that we've seen before. Something else to keep in mind is that the trial administered magnesium sulfate to pregnancies between 30 to 34 weeks gestation. Current guidelines are generally limited to pregnancies less than 32 weeks gestation because all the prior trials didn't go past 32 weeks. And I do want to mention at this time that there was a randomized control trial that was published in 2010 that looked at the same primary outcomes that this study did. And it was basically set up the same way. The biggest difference is that they looked at women who are at imminent risk of delivery between 24 and 31 weeks of gestation versus the 30 to 34 weeks that this study did. And they administered a 6-gram bolus followed by a constant infusion of 2 grams per hour or the matching placebo, depending on what group the women were. And they also had a primary outcome of being a composite of stillbirth or infant death by 1 year of age or moderate or severe cerebral palsy at or beyond 2 years of corrected age. And they also found that that composite did not reduce the risk of moderate or severe cerebral palsy. But when they just looked at just getting cerebral palsy by the age of 2 years of age, it did reduce the risk. So it's kind of giving us the same data, being that it's maybe not going to reduce a patient's risk of stillbirth or their child dying by the age of 1 years old, but it will, or it is significant for reducing risk of a child developing cerebral palsy by the age of 2. And that's the end of the presentation. I know that was kind of like very wordy and there was a lot going on. So if anyone has any questions, please feel free to ask, or if there's anything you want clarification on.
I think one other question that came to mind too is like if they looked at all at any differences between like characteristics of the mothers, like what was their maternal age at gestation, like is this their first pregnancy versus a later pregnancy, like were there any differences within the groups of like the mothers themselves or how they were treated as well, like not just, you know, this placebo group, but other confounders that could be there, because it looks like they're just looking at, you know, these outcomes, but you know, what else could be influencing that maybe they haven't looked at.
Right. So, like I said, you know, they had the inclusion criteria, which it could only be a singleton or twin pregnancy. Any higher order pregnancy, they automatically took out of the study because those pregnancies are at higher risk of preterm birth anyways, right? Most of those, they're going to be delivered early. But as far, and you know, there is a breakdown of the racial components, and also they did mention, you know, like the socioeconomic factors, but by doing the randomized trial, that's how they were taking care of those compounding factors by saying, you know, it's like random chance what group they're going to be in. So that was how they controlled for that. But otherwise they did an in-depth study like, oh, because this person had this risk factor, other than, you know, the only risk factor that they really looked at is whether or not they had a contraindicated use to magnesium sulfate use.
I had a similar question, Alex, but now that we're here on this slide, I was like reading this like placebo group and stuff, and like obviously like most randomized trials have like placebo groups, but like in this case, if they have like data proving that it's like magnesium sulfate does reduce risk of cerebral palsy, like is this really like ethical to do this in this situation? Like was that ever raised as a question with this study?
You know, it wasn't, because these are all like, none of this is like hard and fast, right? Even the studies that were done, because when we were talking about the different studies, there was conflicting data. So because the combined like stillbirth, death, and the risk of cerebral palsy was not significant in studies previously done.
Okay. I guess I'm just
Yeah.
like, I'm more so just like, even though it was inconsistent, if this is like part of like national guidelines, it still raises like an ethical question to me anyways.
Right. No, I agree.
Yeah. I'm just wondering if you like noticed any debate about it while you were like doing research about this.
You know, I didn't see any debate that specifically about like, oh, is this ethical to do? And I think part of that is because the use of magnesium sulfate is not a, it's very commonly used, but you're going to see providers who don't use it. You know, because there are risks, because, you know, even in this study, they did see an increased risk for the mother of developing issues. So I think that was probably why there wasn't like such a big uproar about it. But I will say also, the thing with these trials is, and you're going to see this a lot when you start to work with doctors, people will pick and choose, how they want to apply it. If any of you have recently done your OB rotation, you'll know that the FDA recently withdrew their approval of Makena, which is like progesterone use, basically. So legally now, doctors or OBs cannot tell their patients that progesterone use for the use of like preventing preterm birth is, they can legally no longer say that, but you'll still see a lot of doctors prescribing their patients the progesterone because they've seen success with it before, even though the FDA has withdrawn that. So, people are going to go based on, so doctors are going to, they're going to look at this stuff and then they're going to apply it, but they're also going to use their experience. And if it's worked before, why wouldn't they do it? Especially if it gives the patient the comfort to know that, oh, this has been used before and it's helped.
Yeah, we'll talk more about that later because literally the preceptor I used to work, I didn't even know that was a thing actually. I just learned that, but the preceptor I used to work with used it all the time in his patients that were having difficulty getting pregnant. All right. Does anybody else have comments, questions, or anything, Ananya, you'd want to add?
I had a quick question. So regarding their the author's choices for the gestation age, did they say why they chose that specific age range from 30 to 34? Especially because, as you said, it's typically less than 32. And is there any difference if they split their population based off like the less than 32 versus the other greater than 32 week?
Right. So they didn't make any specific note in the paper about data points between patients who are less than 32 weeks versus the patients who are greater than 32 weeks. So I don't have any way of knowing, like, was there a significant difference between those two populations? And as for why they chose a 30 to 34 week patient population when most of the other studies put the cutoff on 32 weeks, I don't really have an answer for that either. I'm sorry. I don't know if they're trying to see if it would be beneficial to continue to give it, since there has been this wealth of research that has shown that preterm exposure to a fetus to magnesium sulfate has shown to decrease the risk of cerebral palsy. And maybe they were trying to see if can we extend that to even a 34-week pregnancy. But right, like, what is preterm birth? Like 34 weeks is 2 weeks away from 2 to 3 weeks away from when we would feel comfortable saying, oh, it's a full term pregnancy. So I don't know if they were trying to push it and see, like, can we continue to give this with minimal side effects and the most positive gain? But yeah, but they didn't give any like specific reasoning for why they decided to do it 2 weeks past what the other studies had done. Any other questions, concerns, comments?
All right, if not, just wanted to say thank you, Ananya, for the presentation. It was amazing. I definitely learned something today. Sad that Dr. Ware couldn't make it, but things happen, especially in the field of OB. Emergency situations happen. So I mean, definitely understandable, but I'm sure she would have loved it. And usually for you guys that are here, like typically like the physician would help